1, 2, 3.
Welcome to this series of webinars on COVID-19, recorded on behalf of the European Respiratory Society and the Prepare EU Pandemic Preparedness Project. We have a number of excellent speakers from European Centre for Diseases Control, the WHO, and other clinical and research experts who will speak on a variety of topics. We will continue to update the series. We're very grateful to you for contributing questions via the website and social media. We have divided these questions into themes such as virology, global surveillance, infection control, protection of healthcare workers, clinical care and therapies and their outcomes, and vaccine preparation. Our experts will address these as relevant in their presentations or subsequently. Just on the clinical side, we were very interested to see the mild infection in children and your series on infants. Do you have any speculations why children and young people are less affected?
I suppose maybe one of the reasons maybe the immune system is not mature. So in an immature system, because as you know, the attack of these coronavirus is causing, I suppose, overreaction of immune function. So because sometimes, in addition to the invasion, the damage of virus by directly, and also cause a very big change of immune function, or usually is an overreaction. So that's a release of a lot of cytokines and so on. This is causing cytokine storm, and then which in turn would damage just like suicide. Just like I suppose is something. But in children or in infant, their immune system is not that mature, so not fully developed. Maybe one of the reasons.
Okay.
We have also seen some of the patients at the very small percentage of children. They had also had some severe situation, but very few.
Okay, and quite different to influenza then in the infants, really.
I don't think there's too much difference in that. Yeah, because some of the influenza like. Also cause some death in children.
Got it. And going to the other end of the spectrum, those who are much more likely to be infected, those with chronic conditions, I was particularly interested, I think you said about 6.3% of people with chronic respiratory disease. Are these mainly COPD patients, smokers, asthma patients?
It doesn't matter whether they are smoker or non-smoker or ex-smoker. Okay. So I haven't seen too much difference in between smokers. So I did this fact. So actually, some of the smokers also infected. So there's no that kind of things from our data. Okay, but the outcome was quite poor with the combination. I suppose in cancer patients, cancer is most difficult to treat, and also I think hypertension and COPD as well, and some patients with diabetes.
Do you think the hypertension is just a marker of other cardiac disease because or age? Because in its own right, hypertension is surprising in a way.
Oh yes, hypertension, because the original data is not that detailed. You know, we got the data from 553 hospitals. They just majority of the patient they just provide one patient.
Yes.
And they put the whole process. But it's really in a hurry. So I don't think the history is taking really clear in detail.
Oh.
So of course they have I think the COPD patient, the percentage is not as low as that. So in our data with 199 patients, that's the beginning of this outbreak.
Okay, and then obviously one of the real difficulties is the number of patients who required admission to the intensive care unit. Mm-hmm. And I was interested to see the duration of stay is quite long in those who unfortunately die. And have you any algorithm or way yet to predict those on entry to ITU who are most likely to die?
Yes, we have made a prediction. I think I suppose in the slides we have shown that it's further confirmed about that. That I think that's a prediction about the mortality or those. We have 10 indices showing that. So I forgot which.
Okay.
But actually, that's quite correct. It's not that difficult to make a prediction based on these 10 indices. So okay. I think that will be easier to get.
And that includes the lung infiltrates increasing rapidly to more than 50%, and the PO2-FO2 ratio, all of those. Yes, okay, I understand.
Also, but one is very important is the lymphocyte. The lymphocyte is sometimes in some of the hospitals really a very important impact, showing the outcome. If it's less than 0.5, that would be poor prognosis.
Well, that's a very helpful and simple marker. The steroid use, I think it was just under 50%, but was there any protocol, or, I mean, I would quite understand if steroids were given in the people with rapidly progressing infiltrates. What would be the guidance for any intensive care unit now who are starting to treat patients?
I think up to now we have any compare studies looking at the corticosteroid administration. My impression is so we usually do in those patients who develop very fast and deteriorate very fast, we use corticosteroid. Usually methylprednisone, right? And then you can usually 2 to 4 microgram per kilo. So perhaps within 3 to 7 days or something like that. So, but my impression is in some of the small cities, they use quite a long time, say like 2 weeks. But the majority of those patients who've been using corticosteroid too long will delay the shedding of the virus. It seems to be when they are on the corticosteroid, the situation is okay. When they withdraw it, it deteriorates very fast. So this is something I suppose it will delay the shedding of the virus.
Well, that's very helpful. Okay, thank you. I wanted to ask a few questions on logistics and how you managed to expand facilities. We saw lots of coverage of the new hospitals. I was interested at the other end of the spectrum, that how to increase medical care for people who are unwell but not very sick. And I believed you have used sports facilities, and how has that worked? We have something to learn from that.
Well, I suppose that's a method to separate the infected people and the not healthy people. That's the main reason. So because that time, I mean, in Wuhan, that's just mixed. So it's actually totally lost of control because quite a lot of number of the medical staff get infected. So that's a big problem. So at that time, that's also the infected people just stay at home. That's infect their family. So the first priority is to separate, to distinguish that from. So that's where those patients, huge patients, can go. So that's to just set up some simple hospital or ward to ask them to stay there. So to isolate the not healthy person. That's the main reason.
Okay. I was just trying to understand why they had to be there and not at home. Was it because they would just infect many more family members at home with big family?
Yeah, that's right. Okay. Definitely yes.
Okay. And I was just the impact on healthcare workers is obviously still, and even in other countries, of the 35 cases we have in the UK, we already have a number of doctors infected. Obviously is a really major issue. How have you support? I mean, it's a team effort, obviously, and all doctors, medical people have a duty of care. How have you supported the healthcare workers? Are there particular tips you would give us in terms of psychological support and helping the teams? I know it's a difficult question, but it's something we all face.
I suppose that's a big problem in China. So in particular at the beginning. So altogether we'll have 1,700 of the medical staff being infected. Some of them died. So that's really at the first and the very beginning, basically in Wuhan. I think the main reason is two. I think two. One is they had a lot of protective facilities, in particular eyes protection and the eye protection and the so-called futher, and then the protection clothes, and that's very important. And the second one is scare. So that's the medical staff at that time, at the beginning, they didn't know how to protect themselves from infection. So huge patient, huge medical staffs getting infected. So leading to the whole hospital in work at that time. So I think after having got enough provide of the protection clothes and eyes, so I think that the infection rate is really remarkably decreased. I think in the majority of the other hospitals in other cities, and there's a few medical staff getting infected.
Okay, and how did you cascade out that education to the healthcare staff? Did you send them videos? How did you improve the education?
Yes, some education. I think some teaching materials, but most important is because we have got the majority of the cities got some experience of outbreak SARS. They know how to protect themselves. I think the people, the majority of the medical staff, they know how to protect themselves. But at that time, we actually have no protection clothes. Really lack that kind of things. So suddenly I have a huge patient, including staff. So that's totally loss of control.
Yes. I was just talking to a colleague in North Italy, and even they have just over 1,000 patients, but they have some problems with the PPE equipment too, and it being in the right place. So wherever you are, it seems to be a problem. The graphs you sent at the end and the artificial intelligence modelling on the effects of the quarantine is so interesting. It's wonderful data. because I think there were a lot of question marks at the beginning when the Wuhan was shut down, whether this was a good thing to do, but it seems clear that it had a very significant impact. Is that how everyone feels?
Oh yes. I think that definitely is a good procedure. I mean, the government have been taken. I mean, so the expert committee announced there's definitely human-to-human transmission, and also a lot of medical staff being infected. That's a very serious situation. So based on that, I think the third day of that was I remember that's 23rd. So the central had to take the
23rd of January.
Yeah.
Yes. Okay.
Action. So the very strong action, the so-called early quarantine, I should say, quarantine by themselves in the whole country, and then.
Yes. Oh, I'm sorry.
It's very important. Those isolation, really important step.
Yes.
So the prevalence, the incidence of disease declining very fast. That seems declining very fast. I suppose in other countries should be doing something like that.
They have in Italy. I think it may be difficult in big cities in Europe to achieve anything like was achieved in China. I don't know how possible that will be, but at least we have the information to show us.
I suppose I think that's the only way, because we don't have a very targeting medication available for this kind of new kind of virus. So probably that's the oldest way and the most efficient to prevent them from further spreading.
Yes. Actually, picking up on the medicines, the data on the trials, the chloroquine was very interesting. Those trials are continuing, are they?
Yes. It seems to be. I mean, at that time, so it's impossible to do any control study, because the patients are facing the threatening disease, so they cannot act as a control or placebo. That's inhumane. We can only give some single arm and see what happens later.
Yes.
But the turning negative of the virus load, I suppose chloroquine seems to be working that way. Only 4 days or something like that. So I suppose we may, if possible, probably in some other countries should try to have such a test.
Well, yes. I think because it's relatively cheaper, it's repurposed. That is one of the easier drugs to trial. So that information is very helpful.
So I mean, by that dose, I think the toxic side effect is not that apparent. So far we have already done about 200 patients.
Okay. Also, the data and the slides you showed on the sputum within the lungs and the N-acetylcysteine use, that was extremely interesting.
Yes. That's a big problem for us.
Yes.
A big problem. I think I just showed you that's a very sticky mucus. What we have done, of course, we have analyzed Mach 1 and Mach 5. It's a very high concentration as compared with the COPD patient and so on. And then we had found when we give ventilation, that's a big problem. So really different from ARDS. As you know, ARDS only affect the lung parenchyma or interstitial. And then when the PO ratio improved, we can draw gradually of the but actually we cannot do that in this kind of patient, in those patients who had a very strong phenomenon with unsynchronized of the patient and ventilator, indicating that very difficult to breathe for this patient. Why was that? So it's not so that AR is less effective small airway. But however, in this kind of patient, the small airway is really effective. So that's why we are trying to do something like using N-acetylcysteine or some others, even some DNAs.
Yes.
So we're trying at the moment because 6 patients on the ECMO at the moment in my ICU.
Yes. And you lavage with the NAC, did you, or just?
I suppose a lavage NAC. I mean, in those patients with ECMO, we're trying. I suppose we need to do this earlier. So earlier, if we predict the patient is getting deteriorated, we should do that earlier. That's most important.
Okay.
I would like to introduce to you because we just finished some of the data from 3 hospitals. We used hydrogen and oxygen mix.
Yes.
It seems to be working very well. I am happy about that. So I just got the data right now. So from Wuhan and from Guangzhou and 3 hospitals, all together 60 something. And after inhaling this hydrogen and oxygen mixed gas, they improved. The dyspnea improved the 2nd day, and the 3rd day, and the 4th day. So all of them showing really improved. I suppose because at least resist early stage, and also have a good turn to hydrogen and oxygen. It's easier for us.
That's fantastic.
Yeah,
yes, I remember using helium as well in patients with upper airway tumours to relieve symptoms. I'm that age too. So you used it because it was cheaper mainly than that was the main reason. Okay, thank you.
We've been using now in nearly 1,000 patients.
Wow, fantastic.
The majority of them show some improvement.
And you're just using it like with the high flow nasal oxygen therapy. You're just in training into spontaneously breathing patients.
Yes, but compare with high concentration oxygen, by this way, hydrogen plus oxygen is much better.
And what percentage hydrogen in the mix? Because I think we're not familiar with using that.
66%.
6.
And 34 or 33% of oxygen.
Okay. Thank you very much. I'm conscious you're very, very busy and it's evening, so I only have 2 more questions.
All right.
If that's okay. One is, obviously with every episode we learn a lot, and I'm glad the whole epidemic is dying down. I hope this doesn't happen again, but it probably will. How would you, in China, having learnt what you have from this coronavirus, how would you change your plans if this happens again in 2 years, 5 years?
Well, I think it's an issue for the world, for not only China. So there are 3 events of coronavirus infection.
Yes.
So once people found some clue of the coronavirus infection, so actually this event had actually first discovered is that was 26th December. So 3 members in one family got infected, the same symptom. At that time, should be very much aware, but we didn't know what virus it is. But if it is coronavirus, I mean later on, in the next few years, once this infection happened people should be very aware, because this kind of COVID-19 is very contagious. So the mean RO may be close to 3. So as you know, SARS only 2, and MERS is less than 1. So this is very contagious. So that's why it always happen in the family. After man quit. So that's one thing. And second thing is, so really important to control this, to stop this spreading in the early beginning, in the upstream. So that's why we suppose early detection and early isolation is most important.
Yes.
And the third is we should have more research looking at the overreaction and immune response of this kind of disease, and also in the which is very high. Once the patients get deteriorate into serious ill, the survival rate is pretty low because of some pathophysiology characters, which is different from ARDS, from usual ARDS, like pneumonia or some others. ARDS, because ARDS is the main, will be alveolar or interstitial tissue will be very much involved. In this kind of disease, not only alveolar, but also small bronchiola involved. Huge.
Yes.
That's why causing that difficult to withdraw the ventilation, and also difficult to give ventilation.
Yes, okay. And my final question is, I speak on behalf of the ERS. I'm based in London, Royal Brompton, but I speak on behalf of the ERS, and I wondered what you thought the ERS could do as a large global respiratory organisation, both with our links with China and our links globally, what we should do to help our respiratory teams.
Yes, I suppose the ERS should play a very important role in that. So because we have a close relation between China and ERS, and also we are, I think at the moment you have should take that duty, because in Italy the disease is spreading very fast, and I think there are 4 or 5 the outbreak very fast, the disease in of course in Korea and Iran and Japan, and then Italy and France. So 2 of them as in Europe. I think you have a lot of work to do. So how to prevent that in early stage, and also have a good diagnostic tool to make it to distinguish this kind of, because the symptoms is not very specific. So similar to influenza. So we have to distinguish that, because at the moment influenza is still quite high. We should distinguish that. So that's we can do. So the ERS, I think we should have more communication and some symposium and exchange some experience from each other. So because we have some experience, we have some lessons as well. So we be happy to have more connection with the ERS. And
that would be fantastic, because we have the China Day at our Congress, but I think there may be room for even a separate symposium or meeting even to learn the lessons. Is there anything we can do with regards to research links?
Oh yes, I think so. So we have, for example, the immunofunction. We actually didn't know what's happening, and also the respiratory mechanics. So when the mucus is full in the bronchiola, how can we do? What's the ventilator, the parameters? How can we can adjust? It's very difficult for us. how can we do to carry out the ECMO earlier rather than the
Yes.
late.
Yes.
That's the things that need to study to do.
Okay, so we can think about that, but
So I don't think we need to wait until the opening of ERS.
No.
Because that will be September. I suppose the thing is over.
Yes, so we can come back to you with perhaps we could move forward from this basis. But it's been amazing. I'd like to thank you very much indeed on behalf of the ERS and everyone.